Thank you for joining us for today's webinar, Addressing Drug Use and Recovery Stigma in Healthcare. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar through a few ways. If you have questions for our presenter or are experiencing technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenters from Elevyst will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for one PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please note that it will take 48 hours for your CEUs and certificate to be available on your MyIRETA profile because we have to cross-check your attendance records with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenters. Elevyst is a comprehensive consulting group passionate about helping organizations advance their community and public health initiatives. Elevyst offers a broad range of services and expertise to clients within the field of harm reduction, public health policy, and advocacy in healthcare, including training and education, technical assistance, and advocacy and organization. And presenting today from Elevyst is Sean Fogler. And Sean, if you are ready, I will hand things over to you. Close this poll.
Sure. Can you hear me, Marla?
I can.
Excellent. Well, thank you so much, Marla, and thank you, IRETA, for having us to discuss this really important topic. And obviously, I'm probably going to speak for about 45 minutes or so, and then we'll open it up for questions. We certainly won't be able to capture everything in 45 minutes. This is a very complex and challenging topic, but very important, especially in light of the current mental health and substance use crises in this country. And so no conflicts. And so just by way of introduction, so my name is Sean, and I'm a person living in long-term recovery. I've been in recovery for about 9 years. I'm a physician by training, an anesthesiologist. I practiced for over a decade in the Philadelphia area, which is where I live today. And for the past 6 years, I've been working in the public health space, focusing on these issues. I've also been impacted by the criminal legal system, which was related to my substance use disorder. So I've kind of seen and experienced a lot of the challenges, certainly not all, but many of the challenges that many of us face, that either a person who's used drugs or a person who identifies as in recovery, or any of us that have had mental health challenges in our lives. And in terms of Elevyst, we've been around for a few years, and we're very passionate about these issues and really kind of changing the narrative and finding solutions to address drug use, overdose, and addiction in this country. And so, by way of starting, this quote here is from a recent United Nations human rights report, and I think it's really important to keep at the front of our minds when we think about these issues. Laws, policies, and practices deployed to address drug use must not end up exacerbating human suffering. And if you think about many of the strategies, many of our policies in this country, and many of our practices, the way we see people who use drugs and even people in recovery, the way we treat them, and the way we try and manage drug use, really exacerbate human suffering to a level that is really incalculable. I think a lot of our policies and practices are actually driving the problems that we're seeing. And I think, the metrics we're using when we look at overdose and things like that are pretty clear indicators, that we have not done a good job at addressing these things, and we definitely need to shift from a public safety or criminalization approach to a public health approach. And that's a big task, that's going to take all of us. Unfortunately, there is no single solution. So for today, and this is going to be quite quick, but it'll give you an overview of some of the work we're doing, talk a bit about stigma in healthcare, what stigma is, how it relates to healthcare, some research and data that we've collected over the past few years. We'll quickly go over solutions, and the reality is each one of the solutions I'll briefly discuss, we could have an entire talk on, but at least it'll get you thinking, and then the future and some of the work that we're doing now. So yes, this is the inside of an airplane, and I always like to start off with this because I think the average plane in the U.S. seats about 300 people, and every day in this country we lose one of these planes. One of these planes falls out of the sky, not literally but figuratively, and everybody dies related to illicit drug use. If we consider alcohol, which we don't talk about alcohol much, that number doubles, more than doubles. We get to about 700 lives every single day. That is a massive number of people. That is, if we're thinking about drug use, that's 3 9/11s every month. If we add in alcohol, you're talking 6 9/11s every month. And the apathy and the resistance to improve policies is really massive, and it's really a disgrace when you think about it. You would think that there are enough lives, enough people suffering and dying that it would really move us to action, and we're having a hard time doing that. This is from the latest National Survey on Drug User Health. This is not the problem of a few. This problem really transcends every demographic. If you see here, 17.3% of the population has a substance use disorder. I mean, that's a massive number of people, almost 49 million people. And alcohol, obviously marijuana is in there, and that's a whole other conversation that we could have. Opioid use disorder, which many of you are keenly aware of, but it's a big number that affects all of us. And so these challenges are each on their own are massive. Like you think about overdose, mental health issues, the impact of the criminal legal system, which is how we typically like to address these issues, communicable diseases. I put identity there because identity-based disparities are massive. We think about race, LGBTQ, poverty. These identities and all these intersections really create this web that people that can really be almost impossible to break out of. And overlying all of this is stigma, these negative perceptions and beliefs we have about different individuals, different groups. And those negative perceptions drive a lot of our policies, right? So they create this political climate that impacts the social determinants of health, which impact the individuals and the communities that many of you see very far downstream. And so stigma may seem like this kind of amorphous thing, like what really is it? But stigma is creating the environment that, in my opinion, is so dangerous and frequently deadly, that's actually taken lives. It's not the drugs. The drugs are the most proximal cause, but it's this idea of stigma, these perceptions, and the things that it leads to, which we'll talk about. So what is stigma? And this is from a book by Irving Goffman, as very classic definition: an attribute, behavior, condition that's deeply discrediting. And it doesn't necessarily have to be drug use, right? It could be, the color of your skin, it could be disability. I mean, there's a whole host of things, but it's something socially discrediting. It's really like a mark of disgrace, a mark of shame, in Greek and Roman times, they used to brand individuals. We don't physically do that today, but we do it in other ways. And I think that the third thing here, which is really important, that is rarely discussed, is that it's a language of relationships. And I think, especially when we're talking about healthcare, where there's this power differential between, a practitioner, say a nurse or a physician, and a patient comes in and expects to be treated with dignity and care, and with respect, and compassion. And then the healthcare professional, is in a position to either do it or not, and also, to deliver care. And we have these perceptions. The healthcare provider has a perception about somebody who's using drugs or is in recovery, and the patient also has a perception, and it creates, it can be very like healing and trusting. It can be very, powerful. But if it's not, and historically it really hasn't been, there's been a lot of, judgment and shame, and really dismissing these patients and not providing care and trying to get them out the door as fast as possible. And that creates this huge gap, where, people don't ask for help. And I think when we're talking about healthcare, we can put, these things into two buckets. Like, it's either an access issue or a quality of care issue. And those two buckets are really important, because access, not just are the services available, but will somebody reach out for help? Will they come through those doors? Historically, no. And if you ask somebody who uses drugs today, do they want to go to the hospital? The vast majority of people, most of the time, will say absolutely not. And then the quality of care received. And there's a lot of research, on this that shows that there's high levels of stigma around, especially drug use and addiction. Less so around, mental health issues, but still, still quite high around some mental health issues today. So this language of relationships, I think, is really, really critical. This is a classic model. It's something you can, think about. But if you start at labels, we have these labels that lead to stereotyping. We believe, say, somebody who quote unquote is an addict, and we don't like to use that term. These stereotypes, like they're dangerous, they can't be trusted, and these things, cause this separation. And there's status loss, separation, where us and them. And the reality is, we have these ideas about who's using drugs and who develops addictions, but it's all of us. It crosses every demographic. I mean, look, I'm a physician in recovery. Way back when I used drugs and I had a substance use disorder, and I knew many others that did, in the healthcare space. It's not an uncommon. This is not an uncommon condition in healthcare. And the reality is, if we're honest, and I'll show you some data, healthcare professionals and other professionals suffer at higher rates than the general population with these issues. But we have this culture of exceptionalism, and we're special, and these things don't affect us. And let's face it, that's just not the truth. And this idea of separation, us and them, leads to discrimination, right? Many of our policies, actually drive discrimination. And the power differential that I discussed is really important. So this is like a good general model. And there's different types of stigma. There's actually more than these, but I think these are the main ones to think about. And you see this in medicine. So public stigma is just the general, negative perceptions and ideas that the population has around drug use and addiction and overdose and all these things. And a lot of that is fueled by myths and misinformation in the media. It's really decades of drug policy that, people talk about, Nixon, but really it started well before that. Structural stigma is when these negative perceptions and ideas and beliefs are baked into our systems. Self-stigma is when the individual who struggles with these issues, and I know this well, really shames themselves, devalues themselves. It's this like toxic shame. And I think this is one of the most destructive things, because if you believe that you're less than, you're not worthy of care, you're not worthy of being treated as a human being, and you absorb all these messages around, these negative messages around you. I mean, this is how people die. People, they don't ask for help, they isolate, they stay disconnected, because the pain of being judged and taking in those messages and shaming themselves, is extremely destructive, and is really a powerful force. Perceived stigma is what we believe others think about us or drugs or drug use. And that also, can be a huge barrier, obviously, to reaching out for help, or accessing care. I recently saw this. Adam Grant actually had posted this, and I think it's really good, and actually relates to something that we found in our research. Is that when we don't know people well and we stand back and maybe we read a story, or we hear something, it's very easy to put someone on a pedestal. It's very easy to demonize people and say they're bad, they're dangerous. But if you look at the horizontal axis and you go and you move out to the right, and once you get close, once you really like connect with the individual and understand, their experience, um, generally, for the most part, we see them as human. And one of the things we found in our research is that clinicians that spend more time with this patient population, patients that struggle with drug use and addiction, the levels of stigma go down, compassion goes up, the belief and trustworthiness goes up, all sorts of metrics improve. And there's other research too in the stigma research that really shows that one of the most powerful strategies to address this is actually getting close. And it's interesting because most of our policies and practices are aimed at like keeping this group at a distance, right, or as far away from us as possible. Even clinicians that believe addiction is a disease and it's treatable, even those clinicians, and there's research to support this, they don't want to live next to this group. They don't want them to marry into their families. All these things. And so I think this is a good graphic that, we need to get close. We need to understand. We need to treat, we really need to treat them as complete people, as humans. And I just want to mention this could be a whole other conversation, but the Surgeon General put out this report last year on our epidemic of loneliness and isolation. And I really believe addiction is a disease of isolation and disconnection. And a lot of our strategies to address substance use drives isolation and disconnection. Even the criminalization, if you think about it, right, putting someone in a cage, um, that is not an effective solution to addressing drug use and addiction. You can always find a story where somebody says jail saved their life, but generally speaking, and I know this, I'll just say this from my own personal experience. My substance use was really rooted in trauma, childhood trauma, and I was actually at the World Trade Center during the 9/11 attacks. There has been nothing more destructive in my life, nothing, than the impact of the criminal legal system, really the criminal punishment system on my life. Nothing, you know. And so, that really drives isolation and disconnection. And that to me, that's where people die. They die alone, they die isolated, they die filled with shame. Um, and these policies and practices are not just in the criminal legal system, right? They're embedded in our healthcare systems. They just look differently, and in some ways, I think they're more dangerous there because when you go to a healthcare professional, when you go into a healthcare system, you expect to be treated with compassion and dignity, and cared for. And as soon as you say, oh, I'm using drugs, or, I'm in recovery, the conversation changes, right? And that culture has to change, because the reality is today, and there's a lot of great clinicians and hospitals, working on programs. There's some amazing people doing fantastic things, but generally speaking, systemically, um, healthcare systems don't want these patients. They don't want them there. And so we've really got to make a shift. And just, and you're all probably keenly aware of this, addictions, illicit drug use is the most highly stigmatized condition across the board. This was a study that was done in 14 countries. They looked at things like leprosy and obesity, having a criminal record, and drug addiction. Illicit drug addiction was ranked number one. Alcohol, alcohol number four. And we have this hierarchy, right? Even with substances, if you're drinking too much, okay, it's bad, but it's not. But, if you're injecting heroin, injecting methamphetamine, smoking crack cocaine, that's a whole other level. But these are highly, highly stigmatized conditions. And, the negative portrayal in the media, this idea that drug use is immoral, that people who use drugs are dangerous, drives stigma and discrimination and more criminalization. And we see that. We see that in society all the time. I mean, just look at the news, right? There's article after article around these issues. We have very negative perceptions. And I like these quotes because I think, Eckhart Tolle, every addiction starts with pain and ends with pain. The reality is that drugs are not the problem. I mean, I'm not, advocating or saying like, we should just open the floodgates and drugs are fine. I'm saying that's not what actually is the problem. And that's what we seem to be hyper focused on. It's everything underneath, because drug use, and addiction is the drive to find a solution, to uncomfortable emotions or trauma or physical pain or a whole host of things that the individual can't possibly tolerate. But we've criminalized the drug and the people that use drugs. And that exacerbates trauma and pain and disconnection and isolation. And so, as much good work is being done, and compassion and, storytelling and all this stuff to address, stigma and addiction and things like that, we also have to address the criminalization of drugs, and in healthcare systems, how we've embedded all those drug policies into our systems. We really have to unravel that, to change the culture, to improve engagement, to improve care, to improve outcomes. And that's going to take a lot of all of us doing, many, many things. And this, many of you probably know Gabor Mate. He's a physician in Canada, which is where I'm from originally. And he worked on the Lower East Side of Vancouver, which is an area like Kensington, which I don't live too far from. I live in Philadelphia. And he wrote this book, In the Realm of Hungry Ghosts, which is fantastic. I would highly recommend it. And he actually has a newer book that's great too. But he said this: if I had to design a system that was intended to keep people addicted, I'd design exactly the system we have now. And I think that's very true, and I think is very true today. So the impact, we've really hit on all of these things: discrimination, avoidance and secrecy, delayed help seeking. Like, these are things that we want, that we don't want, right? It's the opposite. Criminalization, poor engagement, delivery, and outcomes in healthcare. But a lot of our policies and practices, this is exactly what they're delivering. And it shouldn't be a surprise that we're where we're at in the current climate. And a perfect example of stigma, in healthcare is medications. Now, this is an improvement. In 2021, just 22% of the 2.5 million people with opioid use disorder receive medications. In 2020, it was half that. So, and you probably know recently, like last year, the waiver, there was this X waiver, was removed. But what we're finding is that prescriptions aren't really going up that much. And, people want to know why. And the reason is, there are high levels of stigma, there are negative perceptions, there's beliefs that if you're taking a medication that's an agonist like methadone, or a partial agonist like a drug like Suboxone, that you are still using drugs, that you're not in recovery, that you're not healthy. And that's not just in the general population, that's with healthcare professionals as well. And what other condition do we prescribe medications like we do? I mean, if you think about, and things are changing with methadone, but it's been a grind. These medicines are highly stigmatized. You know, you can prescribe methadone for pain in an office, but you certainly can't, you know, if you want to prescribe it for opioid use disorder, you know, the individual has to go line up around a building, right? Highly stigmatized early in the morning. There's, you know, a whole constellation of rules. If they break one, they frequently are kicked out of the program. I mean, what other disease do we treat like that? None, right? And what other disease do we expect, you know, perfect adherence and compliance? None, right? It's just this, and I think stigma is a big part of that. This is related to the waivers. You know, you could look at this, even when there was a waiver, very few clinicians, like if you look here, Philadelphia is among the top in figure 2 here. Close, like around 6% of providers were waivered. Of the 6% that were waivered, very few used it, or they used it to very low, you know, low levels. They didn't want to prescribe to this patient population. And these are just some articles about, you know, ending the X waiver doesn't necessarily address the issue. Like medications for opioid use disorder are very powerful and change lives. And that's one of the solutions, is definitely to expand treatment and make it low barrier. But the reality is that there are still plenty of places where you can't get these medications, or you know, there's huge resistance for a number of issues. And here's one, you know, pharmacy related issues. Pharmacies don't want to give this medication out. They don't want, quote unquote, these people, you know, coming to the pharmacy. And that's a problem. And there's geographical issues. There's it's a perfect storm. There's so many barriers. And stigma is a big one. And in our first study in 2022, which I'll go into some more detail, but I just wanted to highlight here, you know, we asked this question: is a person who takes medications for their addiction considered to be in recovery? And only 28% of the general population, and this was a survey, and it's kind of it's a unique technology that we used, but we were able to survey 30,000 Americans, and we oversampled Pennsylvania. So we oversampled 10,000 Pennsylvanians, and we found that the general population, 28%. In healthcare professionals, we asked the same question, and we found only 24% believe people were always in recovery. Now, there's this big group in sometimes, right? And, you know, we didn't explore that, but there's probably a lot to unpack there. But the reality is, I mean, if only a quarter of clinicians think you're actually in recovery when you're taking an FDA approved med that we know works, that we know reduces morbidity and mortality dramatically, you know, like, are they going to prescribe? Are they going to want to take care of this patient population? Are they going to want to prescribe this medication? Are they going to advocate for policies and practices in their systems that make it easier to get these medications? I mean, I think hell no, right? If that's the underlying belief, and we have to change, you know, we have to change that. And this, I'm not going to go into the methodology, but we used this unique technology, which is a type of online non-probability sampling that uses inactive domains. And when a person types in or goes to a website that they didn't intend to, they randomly get sent to a survey, and they can opt in or opt out. It's up to them. There's been research on this technology. It's been used by the CDC and the Department of State for all sorts of interesting work. And when we survey using this technology, we get a very representative sample of the U.S. population. It mirrors it almost identically. So the data is quite high quality. And we surveyed the general public. This was in the summer of 2022. Here are some details, and I'm happy to share these. You know, we're talking more detail after. But you can see we had about 30,000 people opt in and about 4,900 complete. And so what that means is, you know, 30,000 people opted in, but they may have left after answering 2 questions, or you can see here we asked 26 questions or 10 questions, and we include those because that data is important, right? If we have 10,000 people answering a question, we'll look at all those 10,000, right? Total completes was about 4,900. And I just want to highlight some facts, and some of you may have seen some of these before. We asked this question: imagine a person who uses drugs or alcohol problematically. Do most people view this person as a member of their community? So 71% of this population believed, an individual using drugs or alcohol problematically are outcasts or non-community members. I mean, just think about that belief and what it may lead to, right? Like high levels of discrimination, like advocating for punishing these individuals, locking them up, involuntary commitment. There's a whole host of things, right? Certainly not if we believe this these individuals are outcasts and they're not like us, which is not true. Then we certainly are not going to be compassionate and dignify this patient population. Inferiority: 69% believe people who use drugs are somewhat, very, or completely inferior, right? They're not like us. Not true, right? Responsibility and blame: 74% of us believe that others view people who use drugs as somewhat, very, or entirely responsible. And this is really important because there's been some research done on this, that if we think somebody can cause their condition and can control their condition, those two things, then stigma's off the charts. Like you chose to use drugs, you can control it. So we shame you, we stigmatize you, we discriminate against you, we do everything we can to kind of punish you into getting better, which we know vast majority of the time does not work. And this is opposed to if you didn't cause your condition, or you can't control it. Say you've been diagnosed with some type of cancer, right? What do we do with somebody like that? We love them, we support them, we throw resources into them. They're worthy, right? This population, no. 3/4 of us, believe this. Problematic. Unpredictability, and this is around fear or greatly fear. And a lot of these fears, let's face it, are just fueled by myths and misinformation in the media, the demonization of drug use and people that are addicted. And that's not the reality of it. Like, the vast majority of people that are struggling with a substance use disorder are not roaming the streets. They're going to work every day. They look like all of us, That was me. I went to work every day. I was high functioning. I never had issues at work, and I was addicted to cocaine, you know. Um, and I'm not alone, right? Especially with healthcare professionals. Passing is really interesting, and I think this is a really interesting metric that we should explore more. And passing's, fancy term, I think, in social sciences for hiding. So imagine a person who uses drugs or alcohol problematic. Does society think this person will try to hide, right? Almost 80% of us. Of course they will, right? They're going to get judged, shamed, they may be criminalized. Absolutely. And I think this would be a really interesting metric to track and look at, to measure like levels of stigma, right? Because if we say this number goes down significantly, right, people feel more comfortably opening up. Yes, I'm struggling. Yes, I'm using drugs. They feel safe. I think that would be a pretty powerful indicator that societal stigma is moving in a better direction, is going down. I think that would be something really interesting to explore. So this last year in 2023, we did another survey where we looked at healthcare professionals. And it's interesting because despite decades of acknowledging addiction as a medical condition, healthcare professionals still receive little training. Like, I was recently at a medical school speaking, and I sat down with the students after, and I was asking them how much education they get. And they told me in their second year in pharmacology, they had a couple lectures on opioids and like other controlled substances. And it basically was like, don't prescribe these things. Like that was it. And then in fourth year, if they were interested in addiction, they could opt into an elective. I mean, considering we're in the midst of a historic, crisis of drug overdose, substance use, addiction, mental health issues, that was shocking to me. And that's obviously not in every medical school, but I mean, we got, as an anesthesiologist, and I was trained here in Philadelphia, we didn't get anything. We watched a video on addiction, and that was it. Now that was in like the early 2000s. I would think we've come much further today, but I'm not sure we have. And what I hear continuously is that there's not time. We don't have time to put this in the curriculum. If we don't have time now, when are we ever going to have time? I mean, it's unbelievable. There's a little bit of research that shows as medical trainees progress through their training, their attitudes towards people that struggle with these issues go down. It's not really surprising. It's really a perfect storm. Like, you have a complex disease, poor training, time, people that are time crunched, frequently attendings, and clinicians that are modeling bad behavior. It's a perfect storm, right? Who's going to want to care for these patients? Really, we're going to try and find ways to get them out of our systems. And stigma, judgment, dismissive attitudes, discrimination has been the norm, and it's been the norm forever. Things are changing. It's not all doom and gloom, but there's increased awareness. People are starting to implement different kind of strategies and programs to address these issues. So things are happening, but it's been slow. And I've said this before. People who use drugs or in recovery are very hesitant, or just flat out refuse to engage with our healthcare systems because they don't trust us, and they shouldn't. They shouldn't. So this study we did, we had a total a little over 24,000 opt-in, little over 3,300 complete. Of this sample, this study last year, June of 2022, we also surveyed 6,000 healthcare professionals, and we stratified them by nurse, physician, pharmacist, social worker. And when we presented the data, we lumped all the groups together because the attitudes and perceptions were almost identical for every group. They were very, very similar across the board. There really wasn't a group that stood out. And so I think this is really interesting. Obviously, this is 2022 is kind of the end of the pandemic. So obviously that may have impacted this, but nearly 30% of healthcare workers in our sample reported currently using drugs or identifying as having an addiction. If we add people that identified as being in recovery, these are healthcare workers, so that number goes to 40%. So 40% of healthcare workers identified as either using drugs, having an addiction, or being in recovery. That's a massive number, right? Massive. We are not unique. I mean, we are human beings, and we struggle with these issues. Obviously, there's other factors that have impacted this, and this was the summer of 2022. COVID had been in effect for a couple of years, but these are big numbers, and obviously this we can connect this to burnout and compassion fatigue and vicarious trauma and like all sorts of other issues. But the reality is healthcare workers use drugs, and they frequently have addictions. Now, one thing, and I mentioned this earlier, one thing that we found is that when clinicians spent more time with this patient population, they had higher levels of belief in the external causes, and when I say external, like the social determinants, poverty, not having a home, criminalization, all these external things, versus internal causes where, oh, you're genetically flawed, you have some immutable disease, you're never going to get better, which is great, right? And there were higher beliefs in trust, competency. There was more belief or more comfort with having somebody with a substance use issue as a neighbor or a coworker. The one interesting thing that I found quite shocking is that is that clinicians that spent more time with this patient population and had these improved, perceptions of the patient population had a far less belief that they could maintain recovery, which is really kind of shocking, but maybe speaks to the fact that, those social determinants or political determinants, there's an awareness that those are very difficult to change. Um, and that's a problem for sure. So there's good and bad in this. And and really, we collected quite a bit of data. I'm just sharing a little bit here because we don't have a ton of time, but I'm going to share this one other data point with you. Between our first survey and second survey, we didn't repeat any questions. I think down the road we will, except for one. And this question was repeated in both the first and second survey. Imagine a person who uses drugs or alcohol. How competent would you say society judges this person to be? And so between 2021 to 2022, we saw, this change in a belief of incompetence go high. Now, this is one attribute, it's one metric, but it's concerning. And you can see in the lower left-hand side, the 2021 survey, the N was a little over 9,000, and 2022, the N was a little over 7,000. But that's a significant bump, right? That there's this belief that this patient population is more incompetent. Interestingly, we looked at political affiliation, and what you see here is that moderates and liberals, their attitudes and perceptions have actually gotten worse, and conservatives have improved. And this didn't really surprise me because, there's a lot of support for harsh, policies that are based in like criminalization or involuntary commitment, things like that, from the liberals, not just conservatives. So this really crosses all party lines. And being in Philadelphia, we just highlighted a few articles here, but the Philadelphia City Council is mostly Democratic, liberal, and obviously a safe injection site is, let's say, on one end of the spectrum in terms of harm reduction strategies that people have a hard time wrapping their head around. But they pretty much unanimously, close to unanimously, ban them. There's support in the state around involuntary commitment, and not just from conservatives. Things that are going on in Oregon with Measure 110, how they're rolling that back. And there's many liberals that are also supporting that. So, these attitudes and perceptions, really cut across all kind of demographics and political lines as well. So many solutions. Like I said at the beginning, I'm just going to hit on each one of these. Each one of these could be a talk, in and of itself. Language is important. Many of you have heard about that. I think that's low-hanging fruit. It's a start. Expanding access to medications, normalizing it, getting rid of the waiver, that's a good thing. There's a lot. Improving naloxone distribution. There are still some places where there's resistance to distributing naloxone, which I find completely makes my head spin. Integrating harm reduction practices into public health and into healthcare systems, and that's actually something that we're working on with the University of Pittsburgh. And I think harm reduction to address stigma, and I'm not just talking the technical harm reduction, like handing out syringes and test strips. I'm talking about the philosophy, the mindset about humanizing individuals, connecting, dignifying, never dismissing somebody, always, just always being there. They say meeting them where they're at, but I think it's way more. But that philosophy and integrating that into healthcare systems is really, really powerful. Evaluate and improve perceptions and practices of healthcare professionals. I think it's critical. Currently, I think community health centers are doing a better job at addressing these things. Currently, I'm not so convinced that our traditional healthcare systems are in a place in terms of culturally to address this patient population. I think they're working towards it, but I think it's going to take time. Integration and coordination of care is really important, and that there's a lot of fragmented, siloed care around behavioral health issues and even substance use issues, and then mainstream medicine. Um, Increased parity, we are still fighting. I mean, Patrick Kennedy passed a bill, I think it was 2009, to reimburse mental health and physical health equally, and we are still fighting today with insurance companies. And we're doing, some work with the Kennedy Forum on some of these issues. Expand access to treatment. That's great. We want high quality treatment. The reality is most people don't go to treatment. Most people don't want treatment. So this is important, treatment, but treatment alone is not the answer. And we hear that, we hear that all the time. Let's, use motivational interviewing and get people into treatment. Okay, maybe we'll get a few more people into treatment, and we want the treatment to be, high quality and evidence-based and, informed by the latest science. But that's one, it's one strategy. Develop metrics to measure and evaluate structural stigma. I think that's really, really important. Integrating people with lived experience into systems at every level, and I mean every level from the top down. Address discrimination and enforce protections. The Justice Department is currently, doing a good job around this. There's many protections within the ADA, the Americans with Disabilities Act, that have never really been enforced. And some, systems and healthcare organizations, they're not even intending to discriminate. It's unintentional. It's just like, this is what we've done for the past 20, 30 years, and nobody said anything, and now they are. So I think that's really important. And I think the ultimate metric is is not just these numbers. Like I think we need to look at how we're evaluating stigma, how we're measuring improvements in stigma, and ultimately it comes down to the experience of the individual that's either using drugs or has had an addiction or has an addiction or is in recovery. What is their life like? What is their experience like? You hear things around like storytelling, and people are watching our videos, and people are doing, these metrics, they are meaningless. They're meaningless. We have to talk to the people that whose lives have been impacted by these issues, and what is their experience like? Because today, when I talk to many, I don't hear that things are that good, and I don't want to paint a dark picture, but I want to paint a real picture. Right? If we're really addressing stigma, then the world will change for these individuals, and their lives will be better. They will get jobs, they will be able to provide for their family, they will get housing, they will not be criminalized. There's a whole host of things that we can, look at. And is there hope? Do these individuals have hope that they have control over their life, that their life will get better? We need to look at metrics that measure that. That's the ultimate. Just a few things, so we're kind of wrapping up. This is a physician support group that I've been involved with for, I don't know, 5 years or so now. There's more and more of kind of these clinician support groups that are popping up, and even groups within hospital systems. Like, I'm doing some work with one system where they actually have groups monthly to discuss challenging clinical experiences. And I think that's really, really important. And I remember my second year practicing as an anesthesiologist, I had found a colleague dead in their call room. And I was on call, and it was back to work. No discussion, no counseling, no therapy. And it was an awful experience. And I think clinicians are exposed to these really unusually traumatic and challenging experiences on a regular basis, and we don't usually we don't give them the support they need or the time. And so I think that's great. I mentioned the Kennedy Forum, and they have this Alignment for Progress, which just kicked off last October. It's a 5-year initiative that's bringing together policymakers, insurers, clinicians, and it's, they're pulling together all these organizations to really shift policy around mental health and substance use care. And we made a commitment to build a coalition of physicians in training, because what I've found is everywhere I've gone and spoken to medical students or residents or fellows, like they are very energized to change the culture. I think some of the old guard, like, guys like me that are practicing out there, they're just doing the work and trying to get through the day. But this younger generation, I think, is excited to really, shift the culture and improve things. And I'm really excited for it. And then here are mailing lists. The other thing we're doing, similar to the 2 surveys here, we're currently working with the Pennsylvania Commission on Crime and Delinquency um, to look at attitudes, perceptions of criminal justice stakeholders towards people that use drugs, people with addiction, people in recovery. We're doing a few surveys like over the next year, which is related to that work. And if anybody's interested, obviously feel free to reach out. And I feel like and I think that's it. I don't know, how did I do on time? Not great. We have 9 minutes, but fast for me. Thank you. Thank you,
No,
Mo. Thank
that
you.
was great. Thank you, Sean. We have it seems there's a great conversation going on in the chat. Some other folks are posting resources. Lots of conversation. We did have a few questions. So regarding that support group that you mentioned, somebody did ask if clinicians are able to go to the support group too.
The Live Well support group?
I believe so.
Yeah, like are they a physician?
She said, I'm a licensed alcohol and drug counselor.
So that group is specific for physicians. There are community groups, but yeah, it really is a closed group for physicians. I'm sorry. I mean, we need one. We need a separate one for nurses. We need a separate one for other types of clinicians. So the short answer is no. My
Okay.
apologies.
And then there was another question. Let me just pull it up. Have any focus groups been done with ER clinicians about their perceived challenges in helping patients with SUDs, especially people who inject drugs? Do you believe it's important to empathize with the experience of clinicians when trying to combat stigma?
Oh, absolutely. I don't think this is one-sided. I think, and I guess I didn't really talk about this, but I think clinicians are put in a very difficult, if not sometimes impossible situation to address these issues. And so so we have not done focus groups, but I think that's, exploring the clinician's experience is really, really important. And it's the other side of the equation for sure. But I also think systems have to take the lead in either wanting to change or being able to implement changes that can support clinicians in providing better care, or at least triaging, this patient population to a place where they get care, if maybe the ER is not the right place, but a place that they can efficiently, hand the patient off. And I think like that's where, when I think about the emergency room, I think that's where we're like warm handoff programs are coming into play, and some are really, really excellent. And that like bridges the gap. But I absolutely think capturing the clinician's experience and understanding it, that's part of the solution for sure.
Mhm.
100%.
Let's see. So no other direct questions, but just one comment that a lot of folks were having conversation about in the chat. Stigma busting can start simply just by changing the way we converse about our patients and their substance use disorders in day-to-day conversation with our cross-discipline colleagues. Advocate for language that is not stigmatizing, model it, humanize our patients. I am grateful to be a healthcare social worker in specialty care where harm reduction is a thing we talk about every single day. It is a part of our provider and employee interview process. We use this SUD industry concept of harm reduction to talk about food and other choices in life as a balance of trade-offs for those in pre-contemplation facing a life-limiting illness. It is a beautiful tool and keeps people engaged by meeting them where they are at.
I love all of that. Whoever wrote that, yeah, absolutely. I mean, that's it. They
And
summed
then,
up the talk in a
yes.
paragraph. Thank you.
Um, and then, somebody just asked, what are your thoughts on psychedelic assisted therapy?
I think that we should be exploring every possible tool. Um, and I think there's been quite a bit of research. I know Hopkins has like a psychedelic lab. Um, yeah, I think we should be exploring everything. We're in the middle of, a massive crisis. But, what we've been doing is not working. It's actually making the problem worse. And I think, psychedelics could absolutely play an important role. I think MDMA, they're finding ketamine. Um, there's a whole host of things. And it's interesting because when you look at the Controlled Substance Act and a lot of these substances that are criminalized, so many of them have beneficial, effects. And we're finding over time, like some that we thought were completely had no medical benefit are having powerful effects, for people. And we need to explore that 100%.
Cynthia asked, what was the name of the book that you mentioned by Gabor Mate? I think it was In the Realm of Ghosts.
In the Realm of Hungry Ghosts.
Hungry Ghosts. Okay.
It's so good. It's
I'll
really,
put,
really good. And he has lots of like talks online. I think yeah, I love his take. And the other one I'd recommend, which I didn't mention today, is a book called The Globalization of Addiction. And it was written by Bruce Alexander, who I think was a psychologist in Vancouver. Um, some amazing writing, and he really talks about this idea of dislocation and isolation and how it creates this environment where drug use and addiction it's just a natural progression of these these political determinants and where society is at. And it really, it gets away from just like I think about NIDA, the National Institute of Drug Abuse, and their model of addiction and how like the drug is always at the center. And I think it's totally wrong, right? The person should be at the center, and the drug is obviously being used, as to find a solution to issues. And a lot of times those issues, probably most of the time, are, are societal things, or challenges with the individual, obviously, behavioral health issues and trauma issues. But The Globalization of Addiction by Bruce Alexander is excellent.
okay. Angela asked to repeat the name of the book again. So that one you did just repeat. And the other one was In the Realm of Hungry Ghosts by Gabor Mate. Um, all right. Well, I believe that is all the questions that came in. Thank you so much, Sean. This was a great presentation. If you're interested, we would love to have you back in the future for anything else you would want to present on.
Sure, thank you.
For folks to, so in the chat, you can reach out to Elevyst at hello@elevyst.com, and that email is in the chat. I'm just going to wrap up here with a few last minute housekeeping items regarding certificates. Thank you so much for participating, everyone. We would like to remind you that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IREDA's website sometime within the next week. Once we have these resources posted, we will send a link out to all of today's webinar registrants. I would now like to remind you of our evaluation and CEU process. You will receive a follow-up email that will include a link to the evaluation, as well as step-by-step instructions on how to obtain your CEUs. Please note that it will take up to 48 hours for your CEUs to become available in your MyIREDA profile. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, thanks so much to everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address is info@ireta.org. And with that, I will conclude today's webinar. Thank you so much again, Sean, Elevyst. Thanks everybody for attending, and we hope you have a great rest of your day.
Thanks, Marla.
Yep. Bye, everyone.